Go ahead and get started here today. I am Katie Frederick, and I am the Digital Content Manager for VisionAware here at the American Printing House for the Blind, and we are part of the APH Connect Center, which houses VisionAware, Family Connect, and Career Connect, and we'll share a little bit more about that later as we move on throughout the webinar, but want to go ahead and get started. I do want to offer the, there has been a slight mix up. So we do have, I will offer the ACV REP credits, but we don't believe those are ready to receive credits for those. So I will give them, but we had some technical issues on our end to be able to make those official. So we will send out an email to everyone when those are ready to be submitted for the certificate. So I will pause the recording here. All right, and I will turn it over to my colleague, Pris Rogers, who I'm very grateful to work with, to introduce today's presenter.
Thank you, Katie. It's really great to be here today and to introduce for another time Kim Ladd, who has presented for us several times on diabetes. Kim is an RN and a certified diabetes care and education specialist. And she's a master trainer for the Stanford University Diabetes Self-Management Program and also the Chronic Disease Self-Management Program, just to name a few of her qualifications. She has quite a passion for preventing diabetes and its complications, and she is involved actually in working with people with vision loss. So she has a really good background for us in terms of doing our diabetes webinars. I hope that you have been able to take the first two in this series. She has done part one, which is of different types of diabetes medications can improve your health, which the one on taking medications by mouth, and the second one on injectable medications. And we hope that you had been able to take those before you came today. And we are offering credit for those as well, but you have to pass a test to be able to get the credit. So hopefully you've been able to take them. If you haven't, please go back and take them. And I'll put the links in the chat after I finish here. So Kim has also updated a lot of material that we have on VisionAware on diabetes, including our guide. And I'll be putting links to that in the chat as well. So I hope if you haven't checked that information out yet, you will, and share it with if you are a professional, with the people whom you serve. If you're a consumer or family member, please be sure to check it out. So without further ado, I want to turn the program over to Kim for our last presentation in this series on medications. Thank you, Kim.
Thank you, Katie and Pris. Hello, everyone. I'm in Virginia, so it's just after 5 here. I'm not sure where everyone else is calling from. I wanted to welcome you. So this third part, it's going to be open for questions and answers. So I do have a little bit of a presentation that I'll go over. So if you were able to watch part one, oral medications, and part two, injectable medications, and you have some questions, we'll take those later. But I also wanted to kind of do a little bit of a presentation as well in case you didn't get to see those, so you won't be completely lost. But I must say, I'm giving the answers to the quizzes, so I might be cheating for y'all, but you would have to watch this one to get the answer. So it'll be okay. It'll be fine. So if you're here, you'll get the answers. That's what you get for attending live. You get to do that. All right, let me share my screen here. All right, so this is diabetes medications Q&A, and I am Kim Ladd. So first, I'm just going to talk a little bit about oral medications for diabetes. These are the questions that were in the quizzes. So I'm going to go ahead and go through the questions and the answers. So the first question was, Metformin is the first line medication for treatment of type 2 diabetes. True or false? And the answer to that is true. So usually when someone is first diagnosed with type 2 diabetes, the first medication a doctor puts them on is metformin. I'll talk a little bit more about that in a minute, but just as a review as well, there are different types of diabetes. There are two that are the most popular. I hate to say popular like in a good thing, but most people that have diabetes have either type 1 or type 2. Type 1 is actually an autoimmune disorder, meaning your body attacks the pancreas for some unknown reason and destroys its ability to produce insulin. So if you have type 1 diabetes, you are not taking medications by mouth for your diabetes. You are taking insulin. So that's why the by mouth medication section mostly relates to type 2. Now, type 2 diabetes, 95% of people that have diabetes have type 2 diabetes. And that is the type that, once again, there's a lot about medicine that we don't know. But, you know, there are some things that we do know. And one of the things we do know about type 2 diabetes is it does have a genetic component. So most people that are diagnosed with type 2 diabetes, someone in their family has it as well, usually a close relative. So I have type 2 diabetes. You know, there are many people in my family that have it. So if you have that genetic predisposition to it, plus risk factors, more than likely you develop type 2 diabetes. The risk factors for type 2 are usually overweight, lack of exercise or physical activity, and eating unhealthily. So that was me. You know, when I got diagnosed, I was like in a bad place. I was extremely overweight. You know, I wasn't eating good. I have the genetic disposition, and I wasn't exercising. So bang, it happened. You know, I've gotten myself together now since I got diagnosed, which is what we want. But that kind of is the difference between the two. All right, so question number 2, sulfonylureas, SGLT2 inhibitors, and DRR4 inhibitors are names of diabetes medications. True or false? So the answer is false. These are actually classifications of medications, not names of medications. Question 3, the purpose of taking diabetes medications is to help keep blood sugar levels under control and to help prevent diabetes complications. True or false? So the answer to that is true. Number 4, the most common side effect of sulfonylureas, boy, these are fun names to say, is hypoglycemia. True or false? And that is a true answer. Number 5, if you cannot afford your diabetes medications, there are no resources or pharmacy programs to help you. True or false? The correct answer is false. Many pharmacies have discount programs. Some of them you pay a yearly fee like $20 or $30 and you get a bunch of medications for free or for like $4 a month. Some pharmacies have free programs that they offer generic medications or specific types of common medications for a cheaper price. Also, the manufacturers of diabetes medications, most of them have payment assistance programs. How you would find out is you would go to the website of the medication that you're taking, and they will have a little blurb on there about, are you having trouble affording your medication? Click here, and then there's a form that you fill out. And then there are also many prescription savings apps that provide coupons to use at a pharmacy, like GoodRx is probably the most popular one. You can go on GoodRx and put your zip code in there. And it is accessible. I've had people use it with the voiceover on their iPhone, and they can scroll through the different screens, find your medicine, and it even has a place where you can tap on the medicine and send a coupon to your pharmacy. So you don't even need to bring your GoodRx, you know, picture from your phone. It'll send it automatically to the pharmacy. So there are lots of programs out there. And that information was sent out with some of the other webinars as well. All right. So now I'm going to talk about why is metformin the first choice for treatment. So I briefly said that pretty much when you're diagnosed with type 2 diabetes, you're put on metformin. So this is a 3-minute video. We're going to listen to David Nathan. He's a professor at Harvard Medical School and director of the Diabetes Center at Massachusetts General Hospital. And he kind of explains in this video, and I think he does a good job of explaining why metformin is the first line therapy for type 2 diabetes. So let me bring that up for you. Give me 1 second. I thought I had it, and there it goes. Technical difficulties. Give me 1 second. If I could multitask, I could talk and do this at the same time, but apparently I'm not that talented. All right, here we go. Share screen. Here we go.
Metformin has been the first choice for diabetes treatment for a long time, and it's a consensus first choice. Everyone pretty much agrees that it should be the first choice. The reason for that choice is that it really fulfills all of the kind of check marks that you'd like for a drug for a very common disease. It is effective at lowering hemoglobin A1C, usually by about 1%. It is very well tolerated, and it's incredibly safe. The final added bonus is that it's really, really cheap. Metformin's been around for more than 5 decades, and its cost is among the lowest of any prescription drug in the world. The major concerns about metformin in the past have been around the issue of lactic acidosis, which is a very severe condition, which can lead to mortality even. But it is just vanishingly rare with metformin compared with its predecessor, fenformin, where it was substantially more common. Otherwise, metformin is really well tolerated. It causes, in probably 5 to 10% of patients, some gastric disturbance, a sense of fullness, sometimes some soft bowel movements, but otherwise is incredibly well tolerated and very safe. The question with diabetes treatment has really gone from how you treat people first, which is usually with lifestyle intervention, trying to get people to lose weight, increase their activity levels, and now, more recently, we've advised that people start on metformin very early in the course, even at the same time as they try to lose weight, because one of its advantages is that it can help with some weight loss. In the past, it used to be that we'd always try lifestyle intervention first with the goal of losing weight, increasing activity levels, but now even many groups are suggesting that metformin be started very early on, right at the time when you identify diabetes, even as you are introducing lifestyle intervention. One of the reasons for that is that metformin is at worst weight neutral, and in most studies leads to the loss of 4 to 5 pounds. So that's an added benefit. Unless there's a contraindication, specific contraindication for a patient to not be on metformin, virtually everyone with type 2 diabetes should be on metformin over the course of their disease. Sometimes as people get older, if they develop kidney dysfunction, we may need to stop it, but otherwise, for the most part, it should be started and then continued over the lifespan of their diabetes. Metformin has been studied in the diabetes prevention program extensively, and of note, it is one of the only, now it's a repurposed drug. I mean, metformin in a sense has been used to treat type 2 diabetes, of course, but has not been approved. It is not currently labeled for prevention. That's important to know. But one of our health economic analyses demonstrated that metformin actually is cost-saving, in the sense of when we looked at the costs of medical care in our patients who were treated with metformin, in part because metformin is so inexpensive and because it reduced the need for blood pressure medicines and other medications, that it actually was cost-saving. And that's remarkable. There's hardly any drug on the planet which looks like it's cost-saving. But metformin, again, may be the kind of an old drug, a 60-year-old drug that is a wonder drug of the 21st century.
All right. So that explained it just a little bit. I get I get the question a lot of why people are put on metformin. So I just kind of wanted to try to help explain that a little bit. The biggest concern that I get with my clients that are on metformin is the GI upset. And I take metformin. I was put on that first when I was diagnosed, and I'm still on it today, 15 years later. And I still have GI upset at times. But the way to help decrease those symptoms is always take it with food. So either take it immediately before eating or eat and then take it. Because if you have something in your stomach, it helps decrease that upset stomach that kind of happens. Or, metformin comes in either twice a day dosage or an extended release once a day. So if you have upset stomach or constipation or diarrhea or nausea and you're taking it twice a day, ask your doctor to switch you to the extended release, which is 1 time a day. And you usually take that at night, and that helps to decrease the GI upset. So that's just a little tip there. All right, let me get back to my slideshow here. All right. So I'm going to go over a few diabetes myths that are kind of questions that people think are true, but they're not really true, and I'll tell you why. So one myth is, I can stop taking diabetes medicines once my blood sugar is under control. So that is a myth. The fact is that some people with type 2 diabetes are actually able to control their blood sugar without medicine. This is done by losing weight if they're overweight, eating a healthy diet, and getting regular exercise. Usually people, when they're first diagnosed, they can make those lifestyle changes and their blood sugar levels will come down. But just remember, it might not last forever because diabetes is a progressive chronic disease. And over time, even if you are doing everything you can to stay healthy, you still may need medicine to keep your blood sugar within your target range. So it doesn't mean that you're doing something wrong. It just means that your pancreas is losing more of its ability to make insulin. So you need to help your body with medicine. All right, the next myth, some natural products cure diabetes. Now, this is a little controversial. I have had, I've been teaching diabetes about 20 years, and I have had, people through the years refuse medications for diabetes, and they wanted to do it a natural way, with herbs or holistic medicine. I am not against those in the least, but in 20 years, I've never had one person successfully treat their diabetes with herbs and holistic medicine. So I'm not to say that it's not possible, but I haven't seen it. And the consensus in the medical field is that it does not work. So currently, there is no cure for diabetes, and any claims that a product can cure diabetes are false. Many herbal or natural products will do little or nothing, and in some cases, they can potentially cause harm. All right, here's a question that I get a lot. The question is, I take 3 different pills for my diabetes. Why so many? It's that many people with type 2 diabetes take multiple diabetes oral medications. The different classifications work in different ways to help lower blood sugar levels. So if one pill alone does not lower your blood sugar levels enough, then incrementally more medications are added. So I'll use myself as an example. When I was first diagnosed, I was started on metformin. So I took only metformin for probably 7 years. And then my blood sugar levels, I had lost weight. I was eating better. I was taking my metformin every day, but my blood sugar levels still were not where they needed to be. So I was started on a second medication, Januvia. And then I was on Januvia and metformin for maybe just a year. The Januvia didn't really do what I wanted it to do, and I was having some side effects from that. So I got switched from Januvia to Jardiance. So then I was taking metformin and Jardiance, and that worked, a couple years. It helped keep my levels down. And then I lost more weight, which means, my blood sugar levels should go down, but it didn't. So that means my pancreas is, losing more of its ability to make insulin. So instead of adding another medicine, my doctor increased my Jardiance to the highest dose. So I was on that for about 6 months and it still didn't do it. So now we're in the present time. About 5 weeks ago, he added Ozempic. So now I take Metformin, Jardiance, and Ozempic, which is actually an injection that I'll talk about in the second part. And that is keeping my blood sugar levels where they need to be. So it is not uncommon for that to happen. Sometimes, even though you're on 3 medicines, you can come off of 1 or 2 if you lose weight or you change your lifestyle habits to more healthy habits. So it's not that you're stuck on that forever, but it's not uncommon for your medicine needs to change. All right, I guess I'll stop right there and see if anyone has any questions about oral medications before we move into insulin and injectables. If there's anything in the chat.
There's nothing right now, but
Okay.
feel free to put any questions in the chat or raise your hand and we can let you talk.
Sounds good. Well, I'll just move on then. And if somebody thinks of something, just put your question in there. All right. So now I'm going to talk a little bit about insulin and injectable medications for diabetes. So here we go again. I'm helping you cheat. These are the questions from the presentation. So the first question was, insulin is a hormone made by the liver, true or false? And that answer is false. Insulin is actually made by the pancreas. Question 2, the main function of insulin is to regulate glucose metabolism. And it's choose the best answer. A, preventing the liver from making more sugar. B, breaking down carbohydrates into sugar. C, releasing glucagon into the bloodstream. D, moving glucose out of the bloodstream and into cells where it can be used for energy. And the correct answer is D. The main function of insulin is to regulate glucose metabolism by moving glucose, which is sugar, out of the bloodstream and into cells where it can be used for energy. The third question, a person with type 1 diabetes has to take insulin to survive, true or false? And the answer is true. If you have type 1 diabetes, which remember I said is an autoimmune disorder that attacks your pancreas, you must take insulin. Number 4, the forms insulin can be administered in are oral, subcutaneous, and inhaled. True or false? False is the correct answer. Insulin can only be administered subcutaneously through a shot or inhaled. You cannot take it by mouth because it will break down in the stomach and your body will not absorb it. That's why insulin has to be a shot, or you have the inhaled insulin called Afrezza. The last question, GLP-1 receptor agonists, such as Victoza, Trulicity, and Ozempic, are non-insulin injectable medications that can be used to help manage type 2 diabetes, true or false? And that answer is true. So I get a lot of people that think because they're taking a shot for their diabetes, that it's insulin. But this is kind of a new class of medications that came out within the last few years. And I'm sure you've seen commercials for it because I hear the commercial every day for like Victoza, Trulicity, and Ozempic. I hear the commercial. They are not insulin. They are an injectable form of an oral medication. It just gets into your body a different way and works a little bit differently. All right, so more myths. My doctor put me on insulin. This means I am not doing a good job managing my blood sugar. That is false. People with type 1 diabetes must use insulin because their body no longer produces this important hormone. People with type 2 diabetes, remember, it is progressive, which means that the body makes less insulin over time. So over time, exercise, diet changes, and oral medications or non-insulin injectable medicines may not be enough to keep your blood sugar in control. And that's when you need to use insulin to keep it in a healthy range. So again, like I said, it's not that you're doing anything wrong. It just means your pancreas is finally pooping out. It's getting tired and not working like it should. All right, another myth, insulin will harm you. That is false. Insulin is actually a lifesaver, but it is difficult to manage for some people. However, over the past few years, there are new and improved insulins that allow for much tighter blood sugar control with lower risk of low or high blood sugar. Testing your blood sugar levels, however, is the only way to know if your treatment plan is working for you. So if you take insulin, you really need to stay on top of checking your blood sugar, either through a continuous glucose meter or by finger stick and a glucometer. All right, another myth. Being on insulin means you don't have to make any lifestyle changes like eating better or exercising. Well, that's a myth. When you're first diagnosed, your blood sugar may be controlled adequately by diet, exercise, and or oral medications. Eventually, however, your medications may not be as effective as they were, and you'll likely need insulin injections to help control your blood sugar levels. So managing your diet and exercise with insulin is very important to help keep your blood sugar levels in their target range and to help avoid complications, because that's the whole purpose of controlling our blood sugar levels, is to avoid complications. That is what takes people's lives and causes them lots of issues, are the complications of diabetes. All right, here's a question. How many types of insulin are there? Now, when I started out like in the late 90s, teaching people about diabetes, there were two types of insulin. There was regular and NPH. The regular was known as clear insulin and the NPH was known as cloudy insulin. That was it. So fast forward 20 some years, and now there are more than 20 types of insulin sold in the US. So it can be very confusing because all of the insulins differ in how they're made, how they work in the body, and how much they cost. So that's when you really want to work with your doctor to help find the right type of insulin for you and your lifestyle. Some insulins you take every time you eat, like regular insulins, which are like fast acting insulins. Some you can take every 24 to 72 hours, like the long lasting ultra lenti insulin. So it just depends on kind of what your needs are and what best controls your blood sugar level. So, two people with a diabetes diagnosis, they could be on completely different medication regimens. And it doesn't mean that one is better than the other. It's just what works the best for you. All right, so now I want to talk a little bit about injections and are they accessible? So I do work in the blind community, helping empower and teach people with blindness that have diabetes how to self-manage every aspect of it. And, I have a lot of success. Just because you have blindness doesn't mean that you can't check your blood sugar levels or identify your medication or inject your medications. There are different ways of doing things, and there are some gadgets that help. So I'm going to spend just a little bit of time with that. First, I'm going to talk a little bit about those GLP-1 receptor agonist injections, which are the Trulicity, Ozempic, Victoza, Byetta, Bydureon, and Adlixin. So remember, these are the shots that are not insulin, and they are for people with type 2 diabetes. So if you have type 1, you're not going to be on a GLP-1 unless it's a real different kind of case. So I take Ozempic. I got to tell you, I have vision, but I like to look at everything through, could I do this if I had vision issues? And I got to tell you, the Ozempic, these GLP-1 receptor agonists, they're all pretty much the same, and they are a little difficult. I have had people that can do it, but it just takes a lot of practice. So basically it comes, let me cover up my name because it has my prescription on it. So let me stop sharing and I can show you what I'm doing here. Okay. So Ozempic, comes in a box. The good thing about it is when you open it up, if you have someone with visual, that can help you visually, it does have really good instructions with pictures and letters. And then you open the flap and there's more instructions. The top part tells you how to prime the syringe, and the bottom part tells you how to give the injection. Giving the injection is not the hard part. The hard part kind of with these medicines is you have to prime it before you give yourself the shot. And it's not really intuitive with how do you know how many times to turn the knob to prime it. So that's kind of the difficult part. Another good thing about Ozempic though, is it comes with the needles. So when you open the box, there's a box inside the box and that has all your needles. And then there's one pen and it looks just like an insulin pen does. It's like a fat pen. I mean, I guess that's why they call it a pen. And basically what you do is you pull off the cap. And I'm not going to open my needle because I don't want to waste it for me, but you grab a needle out and it screws on the end. You can't mess up putting the needle on. It only goes on one way on one side of the syringe. So it's going to screw on and then the needle is ready, but you pull the cap off before you're going to inject it. So now this is the same as an insulin pen. It has this part that you click. It's not real loud, so I'm not sure y'all could hear that or not, but it starts at 0. So when you're priming, the instructions say you need to check the flow with each new pin. So you want to turn the dose selector until the dose counter shows the flow check symbol, which is 2 dots and a dash. So I mean, that's not accessible for you to see. But what I've had some people do, it's usually 2 clicks. So I tell people just to click it twice and then either have someone look at it to make sure it's in the right spot, or you could use Be My Eyes app and have the person get on the line and go, hey, do you see 2 dots in a line? And then they can tell you whether or not that's right. So people that live by themselves, I get them just to use the apps to help with the vision part. So then after you turn it 2 clicks to that priming position, then you have to press on, I'm not going to do it because I don't want to waste my medicine. Then you have to press on the end opposite of the one with the needle. And that will inject a little bit of medicine up to the end of the needle. So you do that to make sure, because you're giving yourselves, I mean, you start off with the Ozempic at 0.25 milligrams. It is a tiny, tiny dose, but you start off at that low dose to help get your body adjusted to it. So the purpose of priming it is to make sure you get your full dose. And then after you prime it, then you're going to turn the knob to your dose. So Ozempic pens or the Trulicity and the Victoza, their dosages are a little bit different, but they all mostly come with 2 doses in them. So the Ozempic, this is a 0.5 milligram pen because that's going to be my normal dose. But like I said, you start off on a half a dose. So when you're doing the half a dose, you're going to have to get visual assistance as well, either through a person or Be My Eyes to make sure you turned it, because there's no rhyme or reason as to how many counting clicks to get to it. You just get to it and it's got to visually go to 0.25. But if you're taking the full dose, you don't need visual assistance because you can just turn it all the way to the end because that's the highest it'll go, and that would be 0.5. So you just need the visual assistance when you're first starting it and when you're doing your starting dose. So, you know, don't shy away from this if the doctor thinks it's going to help you, because there are workarounds. Of note, I do want to talk about these medications though. And this is pretty true with all of them, the Trulicity, the Victoza, the Ozempic. Their side effect is nausea. And boy, I have to tell you, did I ever get nausea? I mean, I started, you do the small 0.25 or half a dose for 4 weeks. And then after 4 weeks, you take your full dose. That first injection that I gave myself, I did it on a Thursday. So Ozempic is done once a week. So I've chosen every Thursday to do it. So I gave my shot on Thursday, didn't have any side effects. Friday, I woke up, I was a little nauseous. Saturday, I felt like I had the flu. I was so nauseous, like I had the stomach flu or something. That's what it felt like. And not to gross anyone out, but then Saturday night, I went into like projectile vomiting. I mean, like one after the other. It was absolutely horrible. And I knew it was this because that's the only thing that I had changed. So I do recommend, if you start it, ask your doctor for some anti-nausea medicine. Luckily, I had some Zofran for another condition, and I was able to take that. And that pretty much is the only thing that got me through the first week of the Ozempic. But on a good note, I've lost 10 pounds. So I always try to find the silver lining. I was so nauseous that I couldn't eat a whole lot. So it forced me to eat less, and I ended up losing weight. And then the nausea tended to go down after maybe day 4, but then I gave myself the next injection on day 7, and the same thing happened, but I didn't have the terrible vomiting. I just kind of had the nausea. So it progressively got better, and I just had to stick with it. And now I'm on week 6, and with my week 5 shot, I only had nausea for half a day on Friday, and then I didn't have it anymore, and my appetite is back. So I just want to tell you that might happen. Most people get that side effect with it, and it scares them. I have a friend who had it, and she had the same thing happen, and she literally thought she was dying because she had never vomited so much in her life. So she ended up going to the emergency room, and they treated her. But thankfully, I knew about it, so I was ready for it. And, it was very uncomfortable, but it didn't scare me to death. So that's why I just wanted to let y'all know that might happen. So you need to decide whether or not that's worth it. Personally, I decided that getting over that nausea was worth it because my A1C has already gone down by like 1%. So I'm already getting the great benefits from the medicine. Plus I lost weight. I always look for a great opportunity to lose some weight because that helps your sugar go down too. And I was able to manage it. And now I don't really have any problems with it. So I guess I'll stop talking about that one, but I just wanted to let y'all know. All right. So the next thing I want to talk about is insulin accessible. So the thing that I tell all of my clients is if you are on insulin, try to get insulin pens instead of insulin vials. So a vial is how insulin always came from the beginning of time when it was invented 100 years ago. It is a glass bottle with a rubber stopper on the top. And what you have to do is you have to hold the insulin bottle upside down, and then you have to take your syringe and push it through the rubber stopper and then pull back the amount of insulin that you want. So first of all, if you have vision issues, it's tough to find that rubber stopper to push through without pricking yourself with the needle. And then you have to be able to see the numbers on the syringe to verify that you've drawn up the correct amount. And I have trouble seeing the numbers. They are tiny. I mean, this one is a 100-unit syringe, so it has a number every 10 units. So I can see the 10 and I can see the 20, but in between the 10 and 20, there are hash marks, and I'm having to really focus, that represent 2 units. So if I needed to take like 14 units, that means I go past the 10 down to the second hash mark, and you have to get it right on the line. And I have a really hard time seeing that because it's so tiny. So, I mean, having vials is not really the most practical thing in the world. But I do want to show you if all you can get are vials, because I know the price of insulin went super, super high there for a while, especially pens. Some pens cost $600 at the height of the crisis. Then the price came down a little bit, but then it went back up at the beginning of the year, and they're starting to come back down again. So sometimes the insurance companies, if the pen price goes super high, they'll say you can't get pens and you have to get vials. So I wanted to show you 2 kind of devices that help if you have to use insulin vial. The first one is called the Safe Shot. So let me get that out. It's a piece of plastic. It cost about, I think last time I checked, I think it was about $12. So Safe Shot is used for people that have a fixed dose insulin, meaning you have an order to take 15 units of NPH insulin every morning, and it never changes. You're always taking 15 units. That's what the Safe Shot is for. So let me get it out. It's this little plastic piece, that you kind of have to feel around because it has little clips on it that hold the needle in place. The needle can only go in one way to make it correct. So you have to make sure that you put it in the correct way. Basically, there's these two pieces at the bottom of the syringe that kind of stick out. Those clip in to the bottom clip on this device. And like I said, they'll only go one way. The top clip holds what's called the shaft of the syringe to hold it in place so it doesn't move. Now, how this device works is there's a little plastic piece that sticks out below the syringe. The plunger of the syringe is the part of the syringe that you pull back to draw up insulin. So with this Safe Shot device, what it does is it stops the plunger into the position to draw up the correct amount of insulin. So basically, this little Safe Shot comes with this little screwdriver that you turn to move the stopper into the correct position. So this one I have set to 60 units of insulin. So I'm gonna, sometimes you need 14 arms to do this. So I'm gonna take my insulin vial. I have that in my right hand. I have the Safe Shot in my left hand with the needle pointing up on the syringe. Then I have to place the vial onto the needle. So I've punctured it, but you also have to hold that syringe in place because you're holding it upside down and it wobbles. So you have to hold that with your hand. With the other hand, I find that plunger on the bottom of the syringe and I push it until it stops. And then I just hold it there for a few seconds and it's going to fill up my needle, my syringe with 60 units. Another way you could do that is, let me put this back in the vial before I mess it up. Before you put the insulin vial onto the needle, pull back on the plunger until it stops and hold it there. Then attach the insulin vial. But to me, this takes much more dexterity, especially if you have low vision and can't find that rubber stopper. Put the vial, puncture the vial with the needle, and then just let go of the plunger and push it up, and it will push air into the insulin vial, and then it'll fill itself. It just takes maybe 10 to 15 seconds. You can help it along by pushing it, but to me, that's more steps. So I kind of prefer putting the vial on and then just drawing back so you have better control over the vial. So you can see, I mean, it is a device that helps. It's cumbersome, but at least it's something that can help if you have to use vials. And I've had, you know, this, most people get pens, but I have had a lot of clients get these and they're able to use it. What most of them tend to do is they just take like a Sunday and they get their insulin out and they get their Safe Shot out and they get 7 syringes or 14 syringes for 2 weeks. And they just sit there and they fill their syringes and then they put them in a container, you know, with either Braille or a label on it or bump dots or something that lets them know that that's their 60 unit syringe, and they just keep them in the fridge. So they don't have to worry about filling a syringe every single time. They're already ready. So, you know, it just takes a little preparation and some homework. So I wanted to tell you about that. That's the Safe Shot. The other device is called the Countadose. So this is the Countadose. This is more expensive. It's about $70 last time I checked. And unfortunately, health insurance doesn't pay for these gadgets. So you either have to pay out of pocket. You would get them on websites like MaxiAids or LS&S. Or if you work with your Department for the Blind for your state, sometimes they can help you get them. It just depends on what they offer in your area. So Countadose is also a plastic piece. It's 2 pieces. It has a small rectangular piece that has rubber. It has 2 holes that has rubber in them. And then it has a plastic piece that kind of sticks out like a really thick toothpick or something. That is what holds your insulin vials. It has 2 slots because remember I told you 20 years ago, there was clear and cloudy insulin, and those were the 2 types of insulin. This thing's been around a long time, so they made it to hold clear and cloudy, because in the old days, you took usually both, and you could put them in the same syringe, so you would only have to give yourself 1 shot. So they have slots here to put the clear insulin and the cloudy insulin, and you can draw them both up into the same syringe. But most people don't do that anymore. Now they just use 1 type because of all the different types of insulin there are. So with this piece, you're going to find the large hole. One side of it has a really small hole, and the other side has a larger hole. So you want the larger diameter hole, and that is where the rubber stopper end of your insulin vial attaches. So it doesn't matter which one you put it in, just put it in one, and you're going to push down until it's snug, and that really holds your vial pretty steady. So that's the good thing. So I'm going to set that down. The other piece is a larger rectangular piece that has 1 clip on it to hold the shaft of the syringe in place. And then it has 2 kind of indentations on the other end of it. One indentation, the parts of the syringe that stick out, I cannot remember the technical name of that, but there's 2 little pieces on the syringe that stick out. That's going to go there. And then the plunger is going to go into the other recessed area. So once again, there's only one way you can put the syringe in. So you just play with it until you get it in there correctly. This one's a little bit more difficult to get in there. Usually I tell people to place the shaft part under the clip first, and then manipulate the bottom part of the syringe to get it in place. So I have it in there. The little part that sticks out is in one indentation, and then the plunger is in the other one. So this one has a dial on it, and it has an embossed plus sign that you can feel, and then below it, it has a minus sign that you can feel. So what that does is the dial that's in between those 2 signs, you can move it. If you move it towards the plus sign, which would be up, it's going to click. You can't hear it real good over the webcam, but it is clicking. Or you can move it down towards the minus, and it'll take the insulin out of the syringe. So this kind of works like an insulin pen. So, okay, so I have my syringe in here. I have my insulin in the other device. Now I have to attach the insulin vial to the needle. So I'm going to take the cap off my needle. So now the needle is exposed. So you have to be careful that you don't prick yourself all over the place. And then you're going to, the plastic part that sticks out of the vial holder, there is a notch on the top of the other piece next to the needle that it fits into. So once again, you can only do it one way. You want to make sure that the side of that piece that contains the insulin vial is to the left, because then it gets punctured by the needle. So when I attach that piece, the needle on my syringe punctures the vial. So now I'm ready to draw up my insulin. So this is used with people that their dose changes. Say like at breakfast, they take 10 units. At night, they take 20 units. So you can use the count dose for both of those doses. And what you would do is you count the clicks. So you need to hold it straight up and down. So the insulin vial is upside down and the needle is facing up, because that's going to draw the insulin out of the vial into the needle, into the syringe. So I'm going to push the count dose up towards the plus sign, and it's going to click, and it kind of has a hard stop. So even if you can't hear the clicks, you can feel the click. So each time it clicks, it's 1 unit. So that was 1 unit, 2 units, 3, 4, 5, 6, 7, 8, 9, 10. So that was 10 units. So then if that's what my dose is, I remove the top part that has the insulin vial, and I take my needle out and I inject my insulin. If I messed up, I can just push that dial all the way down, and it will take all the insulin out of the needle, and I can start all over again. So that's what I like about this one. This one to me is easier to manipulate, because you don't have to hold the vial on top, because the piece that holds the insulin vial is pretty sturdy. So you just can concentrate on drawing up the correct dose. So that's the counter-dose. I think I saw come across where you get these. MaxiAids is a company online. MaxiAids. I think you put it in chat. Thank you, Katie.
I put a link for LSNS actually.
Thank you. Okay, so
there's
LSNS, yes.
Yep.
MaxiAids actually stopped selling the Safe Shot. I don't know why. So you have to get that one at LSNS. But MaxiAids sells the counter-dose. It's through Prodigy.
And I'll
And
find a link
LSNS
for
used
that
to
and post
have
in
it.
the
I
chat
think they
too.
still do. I think they still have it at LSNS as well. So that's those. They do come, the counter-dose comes with instructions. You can either go to the website, or, I mean, it's so old that I have a counter-dose that has a cassette tape that has the instructions that you listen to. But the latest one I got has a CD for instructions. It's one of those tiny CDs, but it'll still work in a CD player. So I haven't gotten one recently, so I'm not sure what format the instructions comes in, but just so you know that. All right, so those are the two devices that can help you with insulin. But like I said, if you can, get insulin pens, because they are the most accessible. So this is a box of Humalog quick pens. Usually you get 5 pens in a box, and they all pretty much look the same. That's why I'm just going to use this one. The boxes of pens do not come with the needles, so those need to be ordered separately. There's all different kinds of needles. These are just ultra fine ones that I have. The good thing is the needles are super tiny now. They used to be a lot longer. This one is, geez, I'm terrible at measurement, but let's see. This one is 5/16 of an inch long. I mean, that is tiny. So pretty much you do this the same way I talked about the Ozempic. You get your needle and you get your insulin pen out. You take the cap off. The end that the cap came off of is where you're going to screw in the needle. So you can't mess it up. There's only one way to put the needle on. So you screw it on. It's ready to go. You take that outer cap off. Now it still has a cap on it for safety. You take that one off last. And then with the insulin pen, it starts at 0. And the first click you hear is going to be 1 unit. So you don't need visual assistance with an insulin pen. Each click is 1 unit. And that's with all insulin pens. So if you're taking 5 units, you're just going to click 1, 2, 3, 4, 5. I listened, I felt it. That was 5. I'm verifying it's 5. And then you give yourself the shot. So that is why insulin pens are the best. But I do want to let you know, some of the insulin pens you have to prime. So you need to find that out. So this one has the instructions in it. So if you can't see the instructions, you know, ask the pharmacist when you pick it up, is this one that I need to prime? Basically, priming just means that you're making sure that the insulin is all the way at the end of the needle, so you get your full dose, like I talked about with the Ozempic. So basically with priming, most of them work this way. You are just going to turn the needle to 2 units, 1, 2, and then push on the trigger button, which is on the opposite end of the needle, and that puts the insulin up into the needle. Then you turn it back to 0, and then you draw up your dose. And then you take that second safety cap off the needle and inject your medicine by, you know, holding your skin or smoothing your skin, injecting it, then pushing the plunger at the other end, and then hold it in place for about 10 seconds because you want to make sure you give it enough time to enter your body. So quick and easy. Insulin pens, I think, are the best creation and the best for people with vision impairments, because I have so many people that do them all by themselves without any assistance or visual assistance, and they do a great job. All right, let me get back to this other stuff. I guess, are there any questions about those? I think some things came in chat and I don't want to miss them, and make sure that I covered them. Or did you already answer everything? Oh, yeah, you
Oh,
did it. So it's all
okay.
about where to get it, I think.
Right. I put 2 links in chat. There's one link for the product from LSNS,
Awesome.
which, and then one for the Maxi aids, and we have a hand raised.
Okay.
So let me get over there. One second. Jean, you should be able to unmute.
Hi, Jean.
Yeah, I am a vision rehab teacher.
Yes.
And so how do you I have a number of questions about just training and working with somebody who is
Okay.
first learning all of this. But how do you practice all of this without using their meds up?
No, it is difficult. You know, I have dummy ones that I use so that we don't waste their meds. So if you don't have any way of getting that, basically I do it incrementally. So like if they have, are you talking about any of the devices like the Safe Shot and the Counter Dose?
And any of the
And the
device-
pen.
even
Okay.
just the pens,
Okay.
for somebody who needs to slow down. I had somebody who could seem not to be able to slow down their turning of the pen to hear the
Yeah.
individual clicks. You know, so all of a sudden they're at like 7 and they think it was just one click.
Right. I know, and that is difficult. The good thing is, even if you're turning the pen, you're not going to waste the insulin unless they actually inject it. So each time you turn it, it's okay. You can turn it to get them to practice the clicking.
Okay.
Then all you do is turn it back to 0 and you're not losing any insulin out of the pen.
Okay.
So they could do that 1,000 times and it's fine. With the Safe Shot and the Counter Dose, it's kind of the same concept. You just have to return the insulin back to the vial. As long as they don't inject it, you can return it back in. And then, I mean, they're going to waste a syringe, but that's a lot cheaper than wasting a vial of insulin. So, yeah, I mean, that's pretty much it. And I know you know, not everybody can do it. If they really cannot, you know, control the clicking, then it's probably not safe for them to do it on their own, because you would hate for them to give themselves too much insulin and then they're in the floor passed out.
Right. And I do remember in one of the videos that I watched prior to this one about how long you can keep something once it's opened. So when you were
Yes.
talking about loading a week or 2 weeks worth of syringes and just having them in the fridge, I guess.
Yes.
About how many days can you do that it's safe so that nothing's happening to the medication while it's sitting in a syringe?
Yes, most of the time it's 30 days for insulin. So, you know, I tell people you can do 1 or 2 weeks and then make sure you use those up and then do other ones so you can keep track of how long they're in there. If they're refrigerated, it's a little bit longer. If they're unopened, you know, and they're in the refrigerator and in a controlled temperature, it's a long time. I mean, it's whatever the expiration is on the box, which might be a year. But once it's opened and drawn up, it's usually 30 days for insulins.
Okay. And the last thing and I don't mean to ask all of these questions in a row.
It's
that may
okay.
not be
It's okay.
connected, is what do you consider, Kim, to be sort of best practices between a diabetic educator and a vision specialist? So I work in rural communities and there's like one diabetic educator. And so I'm never quite sure of, you know, how to work with that person unless somebody is having really, really a lot of trouble. And then it goes back to that diabetic educator. You know, I'm willing to work on, let's practice at home type of things, but only if they're looking like they kind of know what they're doing.
Right. And you know, that's difficult as well. See, I am not trained in, you know, vision rehab. I am a registered nurse and a diabetes educator who kind of has learned about vision by working with a blindness community. So I do find that, you know, they don't really teach about blindness in nursing school or medical school or in diabetes education class. They don't. So I find it that maybe if you approach the diabetes educator and just, you know, have a conversation with how you all can collaborate, because she probably doesn't know about blindness. And you can share your expertise about, you know, doing hand over hand and kind of resources and these devices that might help that she probably doesn't even know about. I mean, that's pretty much the best way. You know, where I am, the state where I am, you know, I'm like the only one that I know of that specializes in blindness and diabetes, and they're not everywhere. But that's the best thing I can suggest. You know, I'll work with rehab. We call them rehab therapists in Virginia. So if I say that, I'm sorry if you don't know what I'm talking about. But, you know, I'll work hand in hand with them. I'll do joint visits a lot of time, so we can work with each other. You know, I'll do the medical technical stuff, and then they will help with more of the practicing and getting devices and using, you know, adaptive equipment, and we work together. So I don't know if that's possible in your area. I know it's harder when it's kind of remote, but I bet the diabetes educator would appreciate a call. I spend a lot of my time teaching diabetes educators about blindness because they just don't know, which to me is astounding since there's so much blindness in the diabetes community.
And the thing that I came to appreciate from the two previous presentations was just how much of different medication and names are there.
It's crazy.
I had no idea, and I doubt that a lot of my folks know exactly what they have, but it's be much more aware of, you know, asking them to find out for sure what they have and what it means to them.
Well, thank you. Yes, I mean, I counted the other day, and it's like 76 medications for diabetes now. I mean, it's impossible for anyone to have them all memorized. So, you know, I have a book that I carry around to refresh my memory, but yeah, there's a whole lot of information. So, you know, just collaborate wherever you can.
Okay, thank you.
Thank you.
Again, if anyone else wants to raise their hand, feel free. If you need to know how to do that, if you're on a PC, you can do that by pressing Alt-Y. If you're on a Mac, it's Option-Y. And if you are using the Zoom app on your smartphone or tablet, you can on the main screen, there's a raise hand button. So.
Well, I'll keep going. And then if there's more questions, this is just a little FYI. I found this interesting. So the future of insulin pens is connected insulin pens. So this might help, you know, depending on how they program them, helping with accessibility. I hope it does. So a connected pen or a smart insulin pen is a reusable injector pen with an intuitive smartphone app that can help people with diabetes better manage their insulin delivery. So it kind of acts like a little computer. The smart system calculates and tracks your doses and provides helpful reminders, alerts, and reports. They can come in the form of an add-on to your current insulin pen or reusable form, which uses pre-filled cartridges instead of vials or disposable pens. So basically the pen, from what I understand, helps determine your dose, tells you what dose you need to give if your blood sugar is a certain amount, and records how much you gave. And it's all done through an app. So hopefully they make the app so that it is, you know, it works with voiceover and is accessible. I'm hoping that's what happens. So basically, there's one on the market now that came out last year called Companion Medical's InPen. And then there's a company called Bigfoot that is developing it now. And then Eli Lilly plans to launch a smart pen the second half of this year, but COVID kind of messed up all these launches. So all of them are getting put off a little bit. And then Novo has this Novo Pen 6 and the Echo Plus. They are approved and being used in Europe, and they're expected to launch in America the end of this year or next year. So hopefully all these things will help people with vision impairments as well. And then I briefly wanted to talk about insulin pumps because I get this question a lot. Are insulin pumps accessible? It's kind of a gray area. My answer to that is yes and no. You know, they change the technology all the time. And unfortunately, most of the pumps now are touchscreen. In the older days, they actually had buttons and you could memorize what the buttons did. And you would be able to give yourself insulin when you needed it by memorizing what button you needed to push. Unfortunately, they've pretty much taken that away now, and it's a touchscreen. So, and there's no app that I know of that I have ever seen that coordinates with your insulin pump to work it. So the app, there's no app that's accessible and the pump's not accessible. So I still have had clients that had, I have a person who has some vision. He has enough that with a magnifier, he can see the screen and he can still use his insulin pump. So low vision, they're probably accessible. I do have one client who is completely blind and she uses a pump, but it's an older version that has the buttons. And I don't know what she's going to do when they finally make that one obsolete, but we'll cross that bridge when it happens. So yes and no, pumps are accessible. There are 3 basic ones on the market now. One is the Omnipod Dash, which is a patch pump. Basically, it's like a piece of, it's a plastic cylinder that's kind of in a octangle, I just made that word up, rectangle shape that is filled with insulin, and it is set to deliver insulin over 3 days, 2 to 3 days. It is controlled by an app. Well, it's not controlled by an app. It's controlled by, it's a device that looks like a cell phone, but it's not, and it's touchscreen. There is an app that goes with the Omnipod Dash, but all it does is give you reports. It's a reporting app. So unfortunately, the Omnipod Dash is not accessible at this time. And then Medtronic has the MiniMed. They have a couple MiniMed pumps, and then Tandem has a couple MiniMed pumps. They also are touchscreen. I think the MiniMed 770G has buttons on it. So, but it still has a touchscreen component too. However, insulin pumps are changing. They're getting what's called closed loop systems or artificial pancreas systems. And the MiniMed Medtronic one has one of the, I think it's a 630G that has the option of using it as a closed loop system. So basically what that means is the pump is programmed to deliver your basal insulin dose, which is a small continuous insulin dose 24 hours a day. And it also can be calibrated to give you your bolus insulin, which is the insulin you give yourself to cover the increase in your blood sugar when you eat. So that's the closed loop system. They're not real prevalent right now, and there's still a few kinks in it, but that is one way that pumps can be accessible. So I'm hoping the future of pumps is they all go to that closed loop system and they have an accessible app that you can use with them. All right, so I'm just going to leave you with these few words. Do your best, take all of your medications as prescribed. If you have questions about your medications, ask your pharmacist, your doctor, your nurse, or your diabetes educator. If you have problems affording your medications, please tell your doctor. They might be able to give you samples or can switch you to a less expensive one. If you stop taking your medications due to side effects or other reasons, please tell your doctor. Your doctors do not know, and they do not want you to go without your medicine. So please have that conversation with them. Learn as much as you can about your medications. VisionAware, a good place to start is the diabetes medication page on VisionAware. It has the information that I went over in the webinars, and then it also has some more resources to get more information. And then have an accessible way to safely identify your medications, to cut down on medication errors. I want you to be as safe as possible. And it is possible to do it. It just, takes a lot of practice and some problem solving, but it is possible to do. So that's all I had, new stuff and a review. So if there are any other questions, I guess we'll take them now, and then I'm done talking.
All right.
And
So
I'm
if
not,
anyone,
okay.
No,
Sorry,
if
Katie, I
anyone
didn't mean to
has-
interrupt you. I was going to say, I didn't see anything pop up.
Nope, Chris and I
Okay.
both put a couple of resources in the chat. You know, if you want to see documents and a recording of this webinar will be available shortly after, probably in about a week or so or more. That website is APH Connect Center, all one word, .org/webinars. So that's where you'll find documents and recordings of webinars that we have done. So I
Thank
do
you all
want
for the
to
nice
give-
messages.
Yeah, I'm going to pause the recording and give our closing credit here. So I put that code in the chat. We'll give folks another minute if anyone does have any last questions that they'd like to ask.
This is Chris. I just want to encourage people, if they're on here and they haven't gone to the other webinars that Kim did, please go take them and encourage other people to take them. Just like Jean brought up, there are a lot of people who have no clue about the different kinds of medications, and it'd be really helpful for the VRTs to know about them and educate the other people. So
Yes, there's a lot of great resources on the VisionAware website, which that is visionaware.org, and there's a whole section on some diabetes stuff, and Kim is graciously working on updating that, and so there's just a lot of really good resources there for you to review, as well as the webinars that Chris mentioned. So
All right, thank you all. I just want to put a plug in for the next webinar I'm going to do. I'm not sure of the date, but it's going to be on managing medication with low or no vision. So it'll be all about accessible medication identification systems and things like that. So there's my plug.
yeah, I saw your name on the with Accessible Pharmacy. Is that the one?
No, the next VisionAware one I'm doing. Yes, I do some
Yes,
things with
okay.
Accessible Pharmacy.
Yes, I saw that.
Yes,
as well
that'll
in
be
December.
December
so
3rd. Yes.
yes, great.
Try to
Yes,
get it
and-
out as much as I can.
Yes. And Chris is putting some links in the chat for the other webinars and PowerPoints. So feel free to check those out.
and also the diabetes section on VisionAware too, some direct stuff like to the medications article that Kim referenced.
Yes.
Yes. And then there's all about diabetes and managing diabetes. There's all kinds of good stuff updated with info on how to do it with vision loss as well.
Great. Well, Chris and Kim, do we want to wrap it up
Yes.
and give everyone a few minutes back in our day?
Yes.
It's the end of the day for me, so I need to probably stop talking soon. But Kim, thank you so much.
You're
And
welcome.
Chris, I
Thank
know
y'all.
You've worked with Kim to organize these, so if you have any closing comments.
No, I don't. She's done a great job again as usual. So
Yes.
thank you.
Yes.
Oh, there was a question
yeah,
when they get an email. Yeah.
Yes, we will send an email about this. And again, we apologize. That was an internal glitch on our part. So we will be in touch with registrants about the credits in the form after the webinar. So thank you for your understanding and patience. And with that, we will bid everyone a good afternoon and evening. And thank you again to Kim. And we will connect again soon.
Thanks, everyone.
Thanks,
Thank
Kim.
you.